Hope you had a nice little coffee break. Thank you for your interaction and your support during the morning sessions and panels that we've taken part with so far. This next session is focused around rewiring social care, and I think it's necessary to start off with a bit of a bold statement. Traditional models of care for ageing populations are no longer sustainable. We all agree with that? Right, so innovation is the only way, it's the only way forward. So I'm delighted to welcome my panel here this afternoon to actually debate this particular issue. So Alexis, can I start with you and give yourself an introduction to the room?
Yeah, lovely to meet you all. Can you hear me okay? Yeah? Be quiet. I'm not sure if it's on. Alexis Edwards, I'll project. With IBM, I am a clinician by background and have spent over 25 years in the digitization of care from the front line through to the community. And really excited to be here today. So thank you for having us.
Brilliant. And Nick, can I get you to introduce yourself?
Yeah, of course. Morning, colleagues. Nice to be here. I'm Nick Davies. I'm the Director of Health and Adult Social Care in the Royal Borough of Greenwich. You've heard from Lisa, my colleague, earlier on, and so we're really pleased to be here today to be part of this discussion. And I think adult social care, local councils, and the voluntary sector are really key to this work. And I think that in terms of what I'm interested to get out of some of the discussions that we're having is in that rewiring discussion. I think we need different types of partnership. We're used to, as local authorities and social care, working in partnership, but where are the new types of partnerships? And I think some of those are being created in this room and through this standard. So delighted to be here.
So essentially, just to build on that, Nick, and I think this is okay for everyone to say this, we don't know everything.
Yep.
Nobody knows everything. We've all got expertise in certain areas, but this is such a wide-reaching plan, programme implementation, that it's okay not to know those areas you're not experts in, and that's where the partnerships come in with like-minded individuals. So brilliant. Thank you, Nick. Richard?
Richard Harding. So I work at the Science and Technologies Facilities Council, just rolls off the tongue. So we're part of UKRI, which is where your taxpayer money goes to fund innovation in the UK. I'm in the digital Disneyland bit of that, so we work with high-performing computing, AI and quantum computing. So we do the really hard stuff at the bleeding edge, but it's all about the application of the technology. So we fight for the technology in the human world and the people in the technology world. Starting my own business when I left university was a fintech startup. Any NatWest colleagues in the room, by the way? I was the largest introducer of commercial finance to NatWest in the north of England.
Thanks, sir. Thank you.
And then went into children's services, and then went into adult services, became a complex care social worker, but with a master's in assistive technology. So how do you kind of get that technology, design it really well, get it into a service, and then scale it? Worked on things like Liverpool Telehealth Service, which is the largest telehealth service in Europe. Horizon 2020 funded projects, AAL funded projects, where we have the largest digital domiciliary care service in Europe, in Liverpool as well. Worked in the dark side of the NHS, the Health Innovation Networks. Any of them in the room? Worked there for a while. And then went to academia, and now kind of bumbled my way into an arm's length non-departmental government body. But at heart, I'm a complex care social worker. I understand that need for doing things different in the community, and you don't tackle health in the hospital. It's kind of too late. You tackle it out there in the world. And for me, it's that health is wealth and wealth is health agenda, and how you bring them together.
Yeah, brilliant. Thank you, Richard. I'll extra spoonful for you at lunchtime. Thank you very much. And then the voice from above, Tommy, are you there? Are you beaming into us? Can you hear us?
Beaming up, Scotty.
Brilliant, Tommy. You're in the room, so a warm welcome. Do you want to just give an intro to your good self?
Yeah, sorry I can't be with you. Childcare challenges, as they are. Like Richard, I'm a social worker. I'm the lead social worker for the Digitising Social Care Programme across the HSC, that's the Department of Health and Social Care, and with NHS England. And I firmly believe that neighbourhood begins with people's stories, experiences, and the practitioners that provide care for people And it's really good to weave in some of our work nationally around digitising social care and how we're supporting local authorities and care providers to amplify the story of social care in neighbourhood health and its integral component part into public health outcomes as a general whole.
Brilliant. Thank you, Tommy. And the technology works. Get in. Thank you very much for that. Right, let's start with the harder sort of doomsday kind of question, really. What breaks first if we don't make the innovation, the changes? How will we start to see things become fractured? I'll sort of pose that as a question to any of the panel. If you feel you've got a perspective or an opinion to offer, then please feel free to come in. So, yeah, if we don't change anything, what do we risk breaks first?
Rachel, I'll come in from my perspective, which is that I think people and families break first if we don't get this right. We know that within adult social care, within the local authority context, we're overspending. In Greenwich, my budget's 200 million, and that's overspending. And yet we're still not able to do as much prevention. We're still dealing with people in a crisis, and we should be getting ahead of that curve. And carers, in particular family carers, are really key to that. And then you've obviously got the workforce challenges as well, with a workforce that's doing some of the hardest, most valuable work in society, but which isn't recompensed or recognised to the degree that they should be. So I think those things break, and those are fairly fundamental to our lives, to our ability to age well. So for me, those are some of the real challenges. There's obviously reasons to be optimistic, but I'll perhaps pause there for other colleagues to reflect.
Yeah, I think just to build on that, I think, people break down, the system's breaking down as you've acknowledged. And I think ultimately, the NHS has really bold ambitions for the next 10 years. And I think those can only be enabled if we bring social care along with it. So I was in an interesting conversation with CIOs sometime last year at like a HET event. And the conversation was around what is the frontline digitization that is required to, make the system more sustainable. And that was really their reflection, is that we could do everything that we want to bring the single patient record to life and the NHS app and NHS productivity through AI and agentic and smarter systems and interoperability. But if we don't take that same care and focus and have that on the social care sector, then the whole record breaks down, right? We know that individuals are more than a collection of diagnoses and lists of scans and reports. They're really a reflection of the realities of life, and that's truly captured in the social determinants of health and really can only be improved by an evolution of the system. And I think the last thing I'll say is that there's so much fantastic work happening across the NHS and the social care and voluntary sector, but because it's happening in sort of an analog way, there's at best a duplication of efforts. And at worst, there is some real inequality across the system because we don't really have a true understanding of what's available where and what's being deployed. So I think hopefully rewiring social care gives us that better view and visibility to what's happening as a whole.
Brilliant.
I'm going to look at this two ways. One from a macro perspective, from an economic growth perspective. So Northern Health Science Alliance did a report on productivity in the north, from the north, and what you see is people over 50 who have more than one long-term condition, 80% of them will lose their job within a year. Kind of not good. Massive impact on productivity, which means that we're not competitive in global marketplace. For the SMEs in the room, we've got one on the table over there. Healthcare is pretty rubbish at scaling technologies, so therefore what happens is these great health and care technology startups build the technologies, it's not adopted in the UK, so guess what, they bugger off. They go elsewhere. So I think we need to start thinking like that. And also from our local authority colleagues in the room, many of them, local authority people, So I was on a call with one the other day who said, if I stop collecting the bins, if I stop looking after my parks, if I stop filling in potholes, I still don't have enough money to fund adult social care next year. So there's some real stark challenges in terms of what breaks. So the economy, local authorities, service provision. So it's a whole host.
Yeah. Wow. I'm glad I asked that question to start things off, but very real and very important. Tommy, did you want to add anything to that?
Well, I would concur with everything that everyone has said, and rewiring social care is, for me, about capturing the data to prove how important social care is to our communities. So as an example, the King's Fund last month produced a really thorough document that said social care not my priority, which is the general narrative of the public. We don't know what social care is, we don't use it till we need it, so it has an identity as something that exists that could support the NHS and public health outcomes, as Alexis has alluded to. But at the same time, if we don't have the data to articulate what is happening, its value, and what it does for society as a whole, we are not going to rewire anything. And as Nick has said, it's people and their stories and their interconnectedness that collapsed and struggled in the crisis because we haven't rewired this and thought about people in the story.
Yeah, brilliant. Thank you for your input there, Tommy. A question for everyone around technology. Where can and where does it add most human value, but on the flip to that, where should never be touched? So kind of, we've got this kind of hang up. I remember Professor Heinz Wolff, bless him. He was involved very early on in the Neighbourhoods of the Future back in 2015, 13, 14. And, you know, technology is never a replacement for human-centred care. We have got an opportunity in terms of some of the innovations that we've seen around technology. So where does it add most human value? Where are there some massive additions, but where are the guardrails in terms of we shouldn't go down that path? Richard?
Happy to start. So what we know from the largest telehealth service in Europe is that if you give people in the community the power and control to look after their own conditions, you get a massive return on investment. So 40% cost savings was the report that they produced there. And what you're doing is empowering citizens to manage their own health, to help them stay in work, help them do all the things that they want to do as part of the community, and keep them away from formal services. If we wire our systems together, into systems, you only get a 3 or 4% return on investment in terms of staff time. So it's a real challenge. I'm not saying we don't need to do it, but the bang for your buck is actually in the community from my perspective. I'll give you an example of some of the challenges though. So you can use mobile phone algorithms to predict falls. Notice predict falls. Anyone who works in social care, you'll have a falls team. When they fall over, you do this. So I went to the team and said, hey, I've got this app that uses your mobile phone to predict if someone's going to fall next week. The answer is, when they fall over, we do this. So there's no money in the preventions. Nobody's actually shifted the dial yet. So, and I was doing that 15 years ago, by the way. That technology is in the Netherlands. So they were the first to adopt that kind of technology. So it's a real challenge about service redesign with the technology experts in the room to help you do that. In terms of where you shouldn't go, black box AI. You know, I think we've all seen the stuff on the news. We're working on something called responsible innovation, so trustworthy, transparent, ethical AI and other technologies. So we need to be asking questions about making sure that what we build, you know where the data's from, the data's not drifting, your models aren't drifting. You can explain it to citizens what you're doing, you can explain it to clinicians, etc. And that really people who know what they're doing have got kind of an eye on this stuff. You don't just kind of, oh, it's a black box, we set it loose in the wild and just hope for the best. So we need to kind of raise the skills profile in these areas. So give you an example, NHS in the Northwest, I've got 150 data scientists. How many have got in adult social care? 0. So we need to be closing some of these skills gaps to enable these technologies and the assessment of technologies.
Yeah, brilliant. Anyone else?
Yeah, I can come in. So to build on that. So it's interesting, when you were talking, I was reflecting on the fact that, so in terms of if you read the initial draft of the NHS 10-year plan, it was all about neighbourhoods, wasn't it? And then they came back, and there was a lot of reflection from the contributors and the evaluation of it, which said it just wasn't quite strong enough. That neighborhoods weren't really going to save the NHS. Now, we all beg to differ, of course, and see the value. But they obviously went into a dark room and had a lot of conversations, and what came out was that the NHS app will be the delivery vehicle for the NHS 10-year plan. And I think that is because of that self-serve aspect, the fact that we need individuals to be able to have authority and autonomy over their care and to be able to interact with it, with their record. And of course, now there's a lot of chat about the single patient record and establishing that longitudinal view of care. And I think that's one aspect that we do really need to focus on, because when we have a view of individuals and their history and their social determinants of health, and that we can then apply AI, I think, as you've said, in a responsible way, to be able to better understand risk and insights and understand the factors that are contributing to the decline of individuals. And I think that's really hopefully the focus. And we've got lots of great examples of that, where in One London, for instance, they're surfacing the universal care plan that's powered by the shared care record in a way that individuals can interact with and share with their carers across care settings. And that's a great example of that. But I do think there is a risk, of course, and we need to be really clear about that in terms of the way that people interact with their record and the use of AI. It should be done in a really governed way, and certainly within the context of an individual's care plan, and then obviously with NHS guidelines and evidence. So I think that's a really important factor.
Yeah, I think there's an assumption that everybody wants to share their data as well. So what we found out from the 4 countries that with the Agile Aging project with to use the mobile phone algorithms to predict functional decline was that 80% of people didn't want to share their data with the local authority because they were worried about getting bunged into a care home. But they were happy for the next door neighbour or the daughter or the son to have the data. And actually, if there's a decline in function, then quite often people would self-activate and they would go to the doctor for a urine infection if they were more risk of falls, or they'd do a chair-based exercise program and lower their risk profile for falling. So there's a general worry that we're going to get swamped with all of this data and we're not going to know what to do with it, and we're going to have to run out and see all these people who are going to fall next week. Actually, that's not the case. The other bit of that is if we have all of this data, then guess what? It's going to cost you to store that data and do something useful with it. Well, yeah, write a blank check to AWS and Microsoft because they're quite happy for you to spend your money on cloud. So we have to think about these modern ways of data collection, kind of European compliant, flexible data consent models. So I might be happy that Tesco have my data anonymously and I get a £40 voucher to spend in Tesco. I might be happy that the university has my data and they can have all of it. And I'm quite happy not to be anonymous, but what if I change my mind? So some of these European compliant, flexible data consent models have been leaning into this for years. So we just need to be mindful of that, especially when you look at some of the cohorts in adult social care, like adults with learning difficulties, for example. So there was a famous thing with Apple where they did an April Fool's Day prank, and everybody, they put in the terms and conditions, you signed your soul to Satan. Everybody signed it, right? Nobody reads the terms and conditions, so how do we do these terms and conditions around data consent that everybody understands?
Wow, that's a really good insight, really good insight. If we had our magic wand and we were suddenly able to implement all of the ideas within the standard, and we'll just for this kind of illustration, we'll assume that everything kind of works exactly as we hope it would. Does it solve the resourcing problem, or does it just shift the problem? So whether you're looking at it from a workforce point of view, whether you're looking at it from a kind of a family carer perspective, does it kind of free up capacity and resource, or does it just move it somewhere else? So just interested in different perspectives around that particular point. Nick?
Yeah, so I think the standard's a real enabler for having those conversations and working those issues through, because I think it has the potential of shifting where the responsibility lies if you approach it in a particular way, which would be as one organisation, as the council, or as health colleagues, or as a partner who's investing in the model. I think if you look at it as a partnership and really take an approach which looks at resources across a place, then that's the way you get through that. And that might sound idealistic, but actually I think there are practical examples of where that can happen and is happening. And unfortunately I wasn't here for when Lisa was talking earlier, because we were having to manage some of the sort of local politics post-elections, so we've been in and out. But and so Lisa may have covered some of this, but in terms of our digital health and care offering Greenwich, that's very much looked at the resources across the Greenwich Pound, across the ICB and the local authority, and you start to move away from some of what we touched on, I think, just before we were coming onto the panel, which is where you get people vigorously signing up to a concept, but not happy to put the money in alongside it because it's someone else's responsibility. So I think that the standard provides a good infrastructure for having those partnership conversations, but it still runs, you still always run the risk with local partnerships, with local politics, that, you know, that becomes fractured. But I'd be optimistic if we can do pathfinder work in this area, if we can show that the standard can work to support some of that, then, you know, it starts to overcome some of those challenges. And that inward investment point that's been made, I think from a local authority perspective and a council and social care perspective, is something we're really keen to explore with colleagues. But a lot of that comes down to data, as people have been talking about earlier, knowing your population, knowing your neighbourhood.
Yeah, brilliant. Tommy, don't feel under pressure you have to say anything, but you're looming large on the screen behind me. So any inputs on those questions?
Yeah, let me just throw in something slightly controversial. I think that if we get neighbourhoods right, it will cost us more as a society. And the reason being is that it's an inescapable miracle of medical intervention that people live longer, whether that's a 5-year-old with complex care needs or your 85-year-old with increasing care needs. People live longer, that is a fact. I think what we're going to do if we get this right is articulate the reality of the cost of that to society, but the trade-off is the potential benefit we get if we get it right, as families, as carers, as people who experience care and people who work in the sector. So that from a political perspective, you can start to say, this is going to cost more, and it's going to cost us more as a society, but this is the trade-off you get for it. Where at the moment, the tension is, it's going to cost us more, but there's no trade-off for us as people who experience care. So I think if we get rewiring right and the standards that we've articulated through this conference come together, I think we can have a more frank conversation to say, inevitably this costs more, but here's a tangible trade-off that you get for that cost. Whereas at the moment, I'm not sure we have that equity.
Yeah, I think it's possibly going one step further as well as this is the cost of implementing what we got here, but let's frame what the cost of not doing it actually is. Richard?
Yeah, I'll give you a practical example of that. So I was the maternity lead additional maternity lead for a Vanguard, and I know I've got the wrong plumbing to be the maternity lead, by the way. We built a maternity app which basically gave mums an e-read book about what the child needs, 0 to 5 years old. We saw a diversion from our A&E departments because mums knew the information before they needed it. 43% diversion from people using the app. So I went to a local children's hospital, you can probably work out which one, and went, hey, can I put a poster up in the hospital about this app? It's amazing, it diverts people away from A&E, and they said, we get 63 quid every time somebody comes in for advice, and we get 170 quid when somebody comes in and sits their ass on a bed. You know what you can do with your app. So we have to have some frank conversations about, is there a conflicting and competing service that we'll have to kill if we're going to do this thing? So I think the standard is absolutely brilliant, which is why I'm still involved here, and I think you've done an amazing job pulling it all together. But we still need to be having some of these brave conversations, and sometimes health and others dominate some of these discussions, where actually the right thing to do is to push it into the community. Another example, men of a certain age, over 50, living in Halton where I live, 40% of them don't go to the doctor. They don't like going to the doctor. So where do you get them? You get them in the community-based asset, which is actually the local rugby club. So what we've done is shifted healthcare into the community. So you have to think very differently about how you do some of these stuff. It's that reconfiguration. What we don't want is primary care networks by a different name, which then springboards onto what you're doing, because that's not what we're trying to do.
No, Very relevant, very valid. Thank you. I'm going to come to the audience for questions. I've got one more question to ask before. It was a question asked earlier, actually, around making progress, building traction with the standards as we move into part two. And I think the question was framed around the low-hanging fruit. So what measures, what kind of individual lines, what metrics can we start to measure and demonstrate that actually the first 3, 4, 5 lines that are impacting on people's day-to-day quality of life are actually showing some benefit here before, just to build confidence and build belief in what we're doing before you go the whole hog, as it were. So are there any kind of early wins, low-hanging fruit that you can think of that may be embedded very early on in terms of that data set?
Happy to have a stab, and Lisa from Complex Care, you'll probably have a slant on this. So the local authorities I've been talking to, you look at the highest cost elements to them: falls, meds optimisation, loneliness, adults with learning difficulties. So these are the things that are costing the most money in the areas that I'm talking to. So leaning into these areas and seeing, right, okay, what can we do to help these, I think is really, really important. Also, to raise the agenda of adult social care in certain circles, not mentioning them too much, bear in mind who I work for, you have to think about what they're measuring. So they're measuring skills, they're measuring growth and productivity, they're measuring kind of start-up, scale-up, high-growth companies that are making it. So we have to kind of come at this from multiple lenses, or else you're just going to get the same thing that you've got last time.
Yeah, I completely agree with that. And I think there's something about knowing the lenses through which you're being judged in terms of some of this work. And I also think that there is, alongside those metrics, a need to join that data up across the system, and we've got some examples of that, but those then lean into proper integrated commissioning of services, because you've got data that supports delivery across multiple partners as well. So I do think it's important to have that shared sort of data set, and we've, I think, developed some of that, and no doubt there's other examples.
But it's outcomes based, isn't it? Not activity based.
Yeah, yeah.
The key.
But I think there's layers of this, and I do also think that the real measure will be, we talked about social care earlier, and if people don't understand what social care is until such time as they need to call on social care, which is often the case, then rewiring something that people already don't have a particularly clear understanding of what it does is quite a difficult challenge to face up to, which is why we need to work on the language, the shared language of what actual social care outcomes can deliver for people. But we've got outcomes frameworks around social care which will not be known about, which, across a broader spectrum, where they're qualitative outcomes for people who are carers, who are people in receipt or lived experience of care. So I think it's important that all of that comes together.
Yeah, I was going to add that, yes, we need to wire this stuff together, absolutely, a given. We need to make sure that everyone has access to the right information to make the decisions that they need to. But then we also need to think about people that want to self-serve. So where is the digital marketplace for me to kind of buy my own care or buy my own grab rail or access apps that might support me? Anyone tell me how many healthcare apps are on the marketplace, by the way? Anyone shout a number out?
300.
340,000. Close. I'll let you have that one. So when I was building the maternity app, there was 8,000 maternity apps out there. So, how do we allow people to kind of go to these, self-serve, download their own technologies, use their own technologies, buy their own technologies, and actually stay safe and independent in the community, versus, okay, is there a digital front door for adult social care? What about for those people who, for example, will never get funded? Well, can we not just give them the information? Can we not link up a directory of services to find out where the technology is or where the services are? And it might be that there's something in the church around the corner from you, which is the right service for you, that is run by a charity. It might not be a formal service. So for me, we need to think quite differently and radically change the way that we do this, and also think about the cost of not doing it. So if we've got people on waiting lists to be seen by people, whether that be in the hospital or whether that be in adult social care, yes, your AI chatbot might make mistakes. Guess what? Humans do too. So 10% of the NLP will make stuff up. It'll make mistakes on there. But if they don't get an intervention, that risk builds up in the community and we're just ignoring it. That will be more financially impactful later on, in my opinion.
Yeah. I'm going to reach out for questions. Pop your hand up if you've got a question. Just to follow on to that, Richard, with regard to customer and beneficiary. So I'm thinking here, is it our elder selves who's the client, or is it our immediate family member who makes that decision? Is there some data out there that tells us who the customer and the decision maker actually is?
Sorry, was that a question?
Yeah.
Oh. Well, I mean, from an e-healthcare perspective, 2/3 of money, I don't know if Ian has more up-to-date figures than me, but what I saw was 2/3 of the money that's spent is actually not commissioned from local authorities' money. It's people self-serving. The silver pound, if you will, is another way of looking at it. So for our SME over there, the bigger marketplace is actually the silver-haired people with lots of cash in the bank. So we do sometimes ignore that kind of element of society. 1/3 of the money is actually commissioned technology-enabled care. So that's your local authorities and others who are actually paying for technology as part of a service. So we do, in terms of who is your customer, we do need to differentiate between the self-servers and those that are kind of part of a commissioned service, for a better description.
Brilliant. Thank you. Eric?
Yeah, hi, Nick. So thanks, panel, for a very good session. I think there's a lot of interesting points that were brought up. In particular, I wanted to bring up the issue of trust. I think it's not low-hanging fruit, but it should be a low-cost amendment. I think I'd like to hear from the panel in terms of what you think needs to be done for trust between NHS and social care to grow and flourish. Until you have, forget the technology. People will share their data if they trust they know what's going to happen with it. There are lots of marketplaces that have been out there, but people don't trust those marketplaces. And so I'd like to hear maybe from each of the panel around how do we build trust between NHS and social care?
Brilliant, thank you. Tommy, we'll come to you first, please.
Well, that's a big question. I think any country that has a functioning health or social care is really crap. But I think fundamentally, having worked in both for quite some time, social care doesn't understand what the NHS does in its entirety, and the NHS doesn't understand what social care does in its entirety, so you kind of other it on a sort of psychological perspective. So I think we've got to articulate, and this is where the data comes in, we have to articulate the value that each of them has to the other and how they benefit each other symbiotically, and that grounded in a person's experience. Nick was talking at the very beginning about crisis and people's crisis, because people view health and social care as an entity to help them in their situation. So I think for me it's a simple thing of using better data to articulate what each other's value is to the other and how that as an outcome is a positive impact to the people that we're trying to support.
Thank you. Anyone else?
I'm happy to come in. So I think it's a really good question, and I think it points to I could talk about government departments, working more closely together and all of those sorts of things, but I suppose from where I'm sitting and standing as a system leader in the Greenwich system, spending the Greenwich pound and having a key role in that, it's really about having those relationships with NHS colleagues and building those at all levels so that trust is there. And that trust comes from some of those individual relationships as much as it comes from some of the the governance and other things that we put in place. So we've got governance, we've got health and wellbeing boards, we've got joint plans, but it's in the day-to-day work of what's in our area called the Healthier Greenwich Partnership, where all of the partners come around together, and you do have difficult conversations about money and outcomes, but you start to build a trust within the partnership and the system that builds parity of esteem for our workforce. Is it perfect? No, but that's, I think, the practical things that we can do on the ground in local places. I won't go into thoughts around how that might change, with the Casey Commission and other things in terms of social care, because that's a bigger question. But there's things we can do now that can make a change. So thanks for the question.
Yeah, there's a few different angles to it for me. I remember when we got a building in Liverpool, it was an integrated building, and when the social workers and the nurses moved in, the first thing the nurses did was bought their own fridge, because they wouldn't share a fridge with the social workers. So the first thing I did was drag the fridge outside and left it in the car park. So you're sharing a fridge, you're sharing the milk. So what I'm talking about is culture. So the first thing that we need to tackle is people, culture, processes, and then digital is the last bit. And I know I work for a digital organisation, by the way, but you can't do the digital without the people and processes bit in place. So we also have to think about the different ways that clinicians versus social workers think. So when I was deploying sensors on for chairs, you get a hospital discharge nurse saying, Tommy can't move off the chair. Okay, we want a sensor on the chair. Okay, so what happens when he gets up? Well, he's not allowed to get up. But he's in his own home. He has the right to get up and go and make a cup of tea. Oh no, we don't want him doing that. Whereas a social worker could go, right, okay, let's put a sensor on the chair. Normal time to make a cup of tea is 5 minutes. Let's give him 5 minutes to get to the kettle, make a cup of tea and get back and sit down. So there's that difference in risk, and that one is kind of trying to empower citizens and the other is kind of very much more binary and risk averse. And the last thing I was going to add was the technology element was, so you've got data and governance, I've got data and governance, and we're going to share this. So you go like that and I go like that. But actually there's a bit in the middle which we need to jointly trust each other on. So we need better conversations about that bit in the middle that we are jointly responsible for. And again, that's culture and trust.
Yeah, brilliant. Alexis?
Yeah, just I think to reflect on what was just shared, ultimately, I love these examples because ultimately both of them are really putting the citizen at the center. And in order to enable that shift left that we've just described in terms of trying to solve for like the larger macroeconomics and the impact on the utilization of the system and everything that needs to change fundamentally in the redesign of healthcare and social care, ultimately we really need to put the citizens at the center and then have the conversation around it. It sounds like where that's been successful is in those kind of partnerships, which is great. And then I absolutely agree with you. I think in terms of the trust around the data, I'm sure this is going to sound a bit cliche, but it is all about the transparency and how the data is used, what it's being used for. And we're in the era of AI, but we're also in the era of explainability. So I think as long as we really center the use of data and technology around that and have it designed in a really citizen-centric way, hopefully we enable that trust and that shift left that we're trying to achieve.
Brilliant. Thank you, Alexis. Right, I've got time for one more question just over here. If we can make it snappy. Thank you, Chris. Go on, just speak. That'll come on. Just shout, Chris. Go on.
Here we go.
There you go.
Chris Jeffrey, Men in the Gap. It's not really a question, more an observation. Having worked with KCC Adult Social Care for the last 4 years, it's making people realise what adult social care can do for them, making them realise that once they're in the system, they're not trapped in the system as people used to think. And also, with our Someone's Listening campaign, it's making them realise that we are... I don't work for KCC, but KCC and other partners are there for them when they need us. So it's not as if they need it now, but it's there for them when they require it, if that's a relevant point.
I think that's a really relevant point, and I suppose what I reflect on is the importance of our voluntary community and faith sector in getting some of those messages out, because I can talk about social care, others can talk about social care, but it's in your community, it's with your neighbourhoods, in your however you define that you're going to take the trust around what you should and could access by way of support. So we need to really, in any models we're developing, do those from the bottom up to get a full understanding of what's needed.
I agree, and I think you bang on, because one of the lessons learned from the Liverpool Telehealth Service was, yeah, you've got these thousands and thousands of people using this service, but what about the step down? What about when they're kind of managing their own thing now and you don't need to be formal services anymore? So that does need to be thought through, because as you scale these things, you can become a victim of your own success. You don't want people to be dependent on your services. That's not what this is about.
Yeah, fabulous. Excellent. So Alexis, Nick, Richard and Tommy, thank you so much for your impact. Ladies and gentlemen, can you give a round of applause to our panellists? A really good session.